We are back after a roll call. It's House Appropriations, Thursday, May 21st, 2026, 10:48 a.m. And we are continuing our walk through S-190, which is related, among other things, to reference-based pricing. And there'll be a couple of amendments after we get through this part. So, Jen.
Also make a change in the provision that was passed in last year's Act 55 that limits hospital claims for outpatient prescription drugs to that are administered in an outpatient or office setting under current law to the cap is 120% of the average sales price for any drug that the hospital charged an insurer more than that as of April 1st of last year. This would change that cap from 120% to 130% of the average sales price. It is connected to some of the financial aspects of Section 2 as it came out of that committee, and it would be deleted, proposed for deletion in the amendment from Representative Black and others. So I think maybe it makes sense at this point to take you to that amendment since it deals with the same topic we were discussing.
It only deals with sections 2 and 3?
Yes.
Okay, so this would be the time to do that, and then we'll go to the other sections of the bill. So this is draft 2.1.
Draft 2.1, and it is from Representative Black and several other members of the House Healthcare Committee. This was after the bill had been voted out of the committee. So it has a few instances, but the substantive one is this first instance. So it would strike out Section 2, which was what we were looking at around codifying provisions for fiscal years 27, 28, and 29, hospital fiscal years, with limits on the amounts that could be charged or that hospitals could get paid by QHPs and the VHI plans. This strikes out that section and puts in a new section that's just a standalone session law. It's not going in statute, still the law, just not going in statute, that would have limitations on hospital reimbursements, still for QHPs and VHI plans, but just for FY27. Just for hospital fiscal year 27. It has definitions in it again, including I've added the definition of Medicare adjusted base rate that we've looked at in combination with the language in the last, in the other version of Section 2. It does not define hospital because it is not limiting. It is not doing any carve out. So it applies to all hospitals within the Agreement Care Board's purview. And it starts on page 2 by saying, notwithstanding any provision of, and that citation is to the Green Mountain Care Board's rulemaking, the requirement that they use rulemaking to do, to exercise their rate setting authority. So notwithstanding any provision of the part that says they have to adopt rules to do rate setting, for hospital fiscal year 2027, the board may order hospitals to reduce their commercial reimbursement rates for QHPs and VHI plans based on a percentage of the Medicare adjusted base rate determined by the board for each item provided and service delivered in Vermont to enrollees in these plans. So it takes out a specific percentage or backing into a percentage through a defined dollar amount and just allows the board to order hospitals for hospital fiscal year 2027 to reduce their commercial rates specifically for the QHPs and VHI plans.
So it's more tailored this way, would you say?
I would say it's more discretionary, gives the board greater discretion.
With the hospital, each of the hospitals.
Right, yeah, so
That's what I mean, sort of more tailored to each hospital situation.
Yes.
Okay.
Yes, I think you could say it is less of a one size fits all.
Right. This is somebody who doesn't know much about healthcare. That's why I ask questions the funny way, but.
Yes. And then it still has language saying that a carrier shall not, or VHI shall not reimburse or agree to reimburse a hospital more than the percentage of the Medicare adjusted base rate that the board specifies, if any, for the applicable hospital fiscal year for anything provided to the enrollees in the QHPs and VHI plans. And then it carries in a lot of the same language about if it's not fee for service charges, what do you do? No balance billing. If a hospital has to reduce its rates more than the reductions achieved through that that authority given to the Green Mountain Care Board, then they're still supposed to target the highest rates, starting with those over 500% of the Medicare adjusted base rate,
Okay,
and still directing the board and DFR to make sure that those reductions show up in rates.
Okay, Lynn.
Okay, so those two groups, the Health Connect and the VHI groups,
Yes.
they do not have the kind, are they going to be exempt from the, what other hospitals have to do if you're looking at reductions of 250% or?
We're not.
Are the other insurance, covered insurances, are they subject to more stringent reductions than these two groups with Health Connect and VHI?
Likely no, because this is giving the board specifically the authority to direct hospitals to focus to reduce their rates for these hospitals. I mean, they could, or for these plans. I would defer to the board on the extent to which they address rates generally, reimbursement rates generally. But the way this has been discussed has not suggested that there would be more stringent reductions, I think, particularly given concerns around hospital sustainability. That this is looking at directing.
Yeah, my question is directed at hospital sustainability, which is a whole other issue. My question is, and maybe it's an E, this is the same language as in the other piece that we have.
E is the
Yeah.
same language, yes.
But if it's going to go and have its budget cut, then they have to start at the 500% and then lower those people that are paying more. I'm just looking at,
I mean, I
It
think
could be
that
the
would be
vice
across the
versa.
board, but
is someone getting favored more as a plan than other plans? And that's the question. It could be paying the rules. I mean, the rules can be adjusted to all kinds of plans, I suppose, if they choose, but is it equity or is it somebody getting favored? That's the question. Either
I mean,
way.
yes, I think this is giving different treatment to qualified health plans and VHI plans. And you can talk to the chair of the committee about the rationale for that. I think
Okay, as
that
opposed to
was
small group or in
a
another.
small group that is purchasing qualified health plans is included in the QHPs.
They are.
Mhm.
I thought they were separated.
No, they're still qualified health plans.
So they would also be included.
If they
in
are
this.
purchasing a fully insured product, they're purchasing from my health.
Okay. Wayne, thank you.
Maybe it's wrapped in the same question, but specifically carving out school employees. So between these two, the amendment and the original draft, can you tell us exactly what's changing in terms of school employees?
I mean, they're still included in the, for whom the rates would be limited, but it's not specifying what the hospital reimbursement rates
So the Green
as a
Mountain
percentage of Medicare would be.
Care Board would determine that.
Right, the Green Mountain Care Board would determine that by hospital, based on their hospital budget orders.
So that I see 250% and the 300% are taken out of the.
Right. Yeah.
So that's,
And that was for fiscal years 28 and 29, which are not addressed in this at all.
so 500 is the upper limit and the Care Board can decide below that?
Not necessarily. It's directing the board to order or allowing the board to order hospitals to reduce their rates. It doesn't give a floor or a ceiling on what it would direct them to reduce their commercial rates for the QHPs and VHI plans too. It just gives them the authority to do reference-based pricing, pricing as a percentage of the Medicare adjusted base rate for those plans for hospital fiscal year 2027, while they work on rulemaking for the broader reference-based pricing statewide. The 500% is if a hospital is required by the board's budget order to reduce its commercial reimbursement rates by amounts that are greater than what can be achieved by doing the reference-based pricing for the QHPs and VHI plans, then it directs the hospital where to start. It says the hospitals should reduce their commercial reimbursement rates that are more than 500% of the Medicare adjusted base rate. So anything else that they have that is over 500%, if they don't have any of those, start with whatever the rates are that are the highest in relation to Medicare.
So this language is less restrictive than the previous language.
This, so this E piece is exactly the same, but B is less restrictive on the board and, maybe less restrictive for an individual hospital that would have been covered by the 3.5 or the 250% or 300%.
That's the more tailored to each hospital as opposed to the one size fits all.
Thanks.
Okay.
Okay. All right. So as far as this amendment, that was really the substantive parts. It strikes out section 3, which increased the cap on the outpatient prescription drugs hospital prices. So it would stay at 120% of the average sales price. And then it struck out the effective date section because it had a whole piece on how to implement that change to the hospital outpatient prescription drug cap, and just put it back in as the act will take effect on passage.
So
We're gonna hop over to back to the regular bill.
yes, please hop back to the regular bill. But before you do, just procedurally, we have possession of the bill. This is an amendment being proposed by members of the Healthcare Committee. Are we going to have to vote on this? Is this being presented on the floor? Do we approve it? Do we say something? I guess we should do a straw poll on it here. Do we do a
If you want to do a straw poll, because it'll save you the time of coming back and doing a straw poll when it's on the floor.
Okay, that's what I was trying to figure out. So we will listen to the bill. We also have a committee amendment, which is a language transfer, and then we would vote it. But this will do a straw poll on separately from the bill. Okay, John,
So just curious, was there a straw poll on this in committee?
in your committee,
Yes,
And what was that?
Chair Black, would you?
that was 740.
Okay. And the original bill was 1010.
Jim.
Okay, so yes. Thank you, Ms. Butcher. I'm sure there's a question.
Go ahead. Oh, sorry.
Chair Black, what was the basis for the folks voting no?
I guess,
No discussion?
there wasn't any discussion. I really don't know. I do know that because this bill had already moved out of our committee and Ways and Means had possession of it, we wanted Ways and Means to be able to hear the amendment while they were doing their walkthrough of the bill. And the amendment was, and maybe this is my fault, and I take full responsibility. The amendment was presented, it was very quick. I don't think that there was really time, frankly, I don't think that there was time for some people to understand what exactly it was doing. And again, I think I take full responsibility. I did hear some concerns of, well, I'm not quite sure. So I did hear that.
So is there any potential place that we could run off the rails with this amendment?
Do you want me to, when I come up?
Yeah, why don't we, because we're not going to vote on it right now. Let's hear the rest of the bill and then we'll get Chair Black up to talk about this. Because she can also explain the reason that they wanted to do this amendment, which is probably would be helpful for us to understand. But we'll get there. Let's go back to the bill.
All right, so now we're back to the bill as it was voted out of House Healthcare. This is section 4 is on hospital outsourcing.
We're on page 10.
We are on page 10. Yes. And there was some, it came to light last year during the hospital budget review process at the Green Mountain Care Board that hospitals were outsourcing clinical services that some people hadn't previously been aware was occurring. And the bill as introduced in the Senate would have put some limitations on that. This is taking a step back and gathering some information. So it says for fiscal year 27 hospital budgets, the Green Mountain Care Board shall direct hospitals to provide such information as the board may require regarding the clinical services that the hospital outsources to external entities. And by January 15th of 2027, the board, after consulting with hospitals and their contracted independent providers and assessing the impact of outsourcing on access and quality and availability of care, will provide findings and recommendations on hospital outsourcing to House Healthcare and Ways and Means and the Senate counterparts. And in addition, the board, in collaboration with the Agency of Human Services, will report on the extent to which hospital outsourcing affects provider tax revenue and recommend any needed changes to the provider tax statutes to appropriately reflect expenditures for patient care at Vermont hospitals.
Is this related to the fact that the federal government is requiring us to reduce provider taxes?
No, it is not.
Okay. Lynn?
Is this targeted at things like these birthing centers that are independent or?
No, this is looking
What
at,
is it
there was
looking
some, I believe some hospitals outsource their emergency departments to independent contractors who are delivering, providing services in the hospital facility, but are not employed by the hospital.
Yeah.
Some of the billing then doesn't go through the hospital and doesn't get reflected in provider taxes, although the services are being delivered in Vermont.
That's actually very common from what I understand.
I think it has
Just
been
like radiology.
fairly common in the radiology
Yeah,
and lab
radiology.
services
Yeah.
areas. From testimony I heard, it may be less common or less known for things like anesthesiology, emergency departments,
Yeah,
inpatient departments, or hospital-based departments.
that's been going on for a long time for ERs. I would suspect most of them contract out with an ER. Did you hear? Well, never mind.
So you will find out more when the reports come back.
Reports, right. Okay.
Section 5 deals with reference-based pricing as it relates to healthcare professional bargaining groups. Under existing law, the Green Mountain Care Board can approve creation of healthcare provider bargaining groups. And there are certain things that they're authorized to negotiate on behalf of providers on, but this would would say, notwithstanding anything in this section to the contrary, the Green Mountain Care Board is not required to negotiate with a provider bargaining group or engage in a non-binding arbitration process in connection with the board's establishment of reference-based prices in accordance with the various statutory provisions. Section 6 is on appeals of Green Mountain Care Board orders, and this is largely codifying what has been the existing practice. Under its enabling language, the Green Mountain Care Board is directed to adopt procedures for administrative appeals of its determinations, and then those, the issuance of the final order and record from that would serve as the basis for judicial review at the Vermont Supreme Court. In practice, there has not been an administrative appeals process, and appeals go directly to the Vermont Supreme Court, and so this would eliminate references to administrative appeals because there aren't there present. Section 7 and 8 deal with data infrastructure and a new health system performance tool. This amends an existing statute that requires the Green Mountain Care Board to have an interactive price transparency dashboard. And this directs the board to develop and maintain a public interactive tool that displays information on health system performance, including information on quality, access, and affordability, and to update it regularly. Section 8 says the requirement to develop this tool is only required if the board receives sufficient funding from the federal government or another source for this purpose. And I don't know if we know if that has been received. Yes, we do know, thank you.
Okay.
So there's,
That's good. So does this mean I could go onto the website and find out how much my standard surgical procedure will cost at each
That's
hospital?
under the-
That's too far.
I think that's the existing law requires the board to have a public interactive internet-based price transparency dashboard allowing consumers to compare prices. This is really would be more about health system performance.
Oh, so how's my hospital doing?
How's my hospital doing? How easy is it to access care? Are people able to access care for a particular condition? I don't know exactly what it's going to look like. So the board will have more information, I think, when they develop it.
Okay.
Our last substantive section here is on critical access hospitals and Medicare outpatient cost sharing. And I think the leading language is a fairly good summary of the situation if this committee is not aware of it. It says the General Assembly and Green Mountain Care Board have recently become aware of a federal requirement that Medicare beneficiaries have to pay bear financial responsibility for 20% of the amount charged. Gets back to our charges versus payments discussion. So 20% of the amount charged for outpatient services delivered by critical access hospitals, not 20% of the amount that Medicare pays for the service. So again, Medicare beneficiaries have to pay, are responsible for 20% of the charge, not 20% of the Medicare allowed amount.
That's, whoops,
Yeah, go ahead.
that's significant, right?
Yes.
And we're doing this because
So this is a federal
the
requirement.
feds are making
We
this.
have, well, it's not new. It's been in place for a number of years, but it was
Okay.
not necessarily on people's radar, including my own. It's my understanding this was brought to the board's attention by a public comment. And so as it's been looked into more, there's been, a lot of interest in ways to address. So it continues to say, while the General Assembly understands it cannot invalidate this federal requirement, it also recognizes both that it has a significant unfair and negative financial impact on Medicare beneficiaries in the state's most rural communities, and that Vermont's critical access hospitals are some of the state's most financially vulnerable healthcare facilities. And so the intent of this section is to provide information to Vermont seniors and other Medicare beneficiaries about the federal requirement, while a working group tries to come up with appropriate and enduring solutions that don't undermine the financial sustainability of our critical access hospitals and that comply with federal law. There are significant complications in this area.
Right, so it's costing seniors more, and if we were to just change it, it's gonna hurt our hospitals, our critical access hospitals, potentially their financial situation. So
Right.
we're kind of in this
Right,
awful
and,
place.
right, and there are federal limitations on what we can
Can actually do.
about it, right?
Wayne, and then I think Dave
So
probably.
how long has this federal 20% thing been in effect?
20 years-ish, yeah, approximately 20 years.
And is there any potential liability of the state? We have not been following that for 20 years.
We have been following, I mean,
That's the
it's,
problem.
right, it's been, Vermont seniors have been paying this 20%.
They don't need to.
Well, they do need to.
Yeah.
It's the way the hospitals charge. And there was a great article in one of our, I don't know, it was 7 Days or who it was in, and I remember reading that article that said, if you go to a critical care access hospital for the same procedure and then you go to UVM, it actually costs, you end up paying a bill that could be 2 to 3 times higher of what you would be paying if you'd gone to UVM. And they explained the math in there, which I will not attempt to do here because I can't remember, but but
Right.
it's because of this Medicare thing.
If you end up paying more than what Medicare will reimburse the hospital doesn't keep the money. The
It
hospital
goes back
has
to
to,
Medicare.
right, the hospital has to send the excess to
So
Medicare.
we're paying more as a Medicare beneficiary, and the extra money is going back to the feds.
Yeah, so we're not getting the full benefit that we could get from the
So
Fed.
this is outpatient services at critical access hospitals. And there is a lot of attention on this issue now
Right.
on the various stakeholders, including the critical access hospitals. And so this requires that by September 1st of 2026, each critical access hospital must do all of the following. They must identify all of the outpatient services for which the amount that the hospital charges equals 5 or more times the Medicare allowed amount for that service. They must post prominently on their website and in their outpatient departments disclosure about the federal requirement that Medicare beneficiaries have to pay 20% of the charge for outpatient services, that Medicare beneficiaries may be able to receive care with reduced out-of-pocket costs from other providers, and how to contact the hospital's patient financial assistance department for more information. And it requires the hospitals to file their proposed disclosure materials with the Green Mountain Care Board for approval before posting. And then it also says that to the extent the Green Mountain Care Board tries to address this issue in hospital fiscal year 2027, it must consider any proposals from the critical access hospitals and other interested stakeholders, and must ensure its actions are consistent with ongoing hospital transformation efforts and the principles for healthcare reform that are codified and are sometimes referred to as the Act 48 principles. And then the effective date as amended by the Representative Black and others amendment would just have the effective date say take effect on passage and would change the title of the bill to an act relating to reference-based pricing and the Green Mountain Care Board, because as you may have noticed as we went through, there was no mention of creating a public employee health benefit authority in the House Health Care version of the bill.
Lots to digest. Questions, Lynn?
Okay, the effective date, section 10 is, it'll take effect on passage. Excuse me, in the original bill, it's got a lot of language there.
Yes, because that was related to that section 3
Yeah.
price to the average sales price cap.
So we already took those out.
So if the Representative Black and others amendment is successful, section 3 comes out and you don't need
All that.
all that other stuff.
Thank you.
Any questions at the moment?
The other amendment, or do you want to
Why
go to
don't we-
Representative Black?
Why don't we look at the other amendment just quickly and then we'll get to your Black. And Noah, do we need to have you come on? I'm not entirely sure why. I think this came because of the public health benefit study, which was an appropriation, which we since took out, but because it was in the underlying bill, that's why we're getting this bill. Do I have that right, Nolan?
So I mean, I can, for the record, Nolan, I don't think I can stop this. I mean, what I told Ways and Means, they had the same question, whether they said, I think it was coming here, it's one that potential impacts on the ed fund down the road. Right, because,
If the VHI premiums are reduced,
Reduce, that would help the ed fund.
right.
yeah, if,
If, I know, there's a lot of ifs and everything, yes, in this. Yeah,
and then there was stuff around, provider tax. So,
okay.
there's no this.
I think it was the
It
money,
was at 50,000 for the
the
public.
money as it came over from the,
Yeah.
and I
So
think
if there was ever a whiff of money in appropriation, we end up seeing the bills.
I think the money was in the Senate's budget as it came over, but
Yeah,
maybe it has been modified.
Okay.
It's been doing comments.
Okay, so let's show our amendment quickly.
All right.
Dave, did you have a question before we get to? our-
No, I'll get it from.
Okay.
Thank you.
Okay. This is what I talked about, because it's really related to this bill, sort of, we're just gonna take it out of the budget and stick it in here.
Right, so this would add a new section 4A on reinsurance and the authorization to pursue a section 1332 waiver. This would authorize the Department of Vermont Health Access in consultation with the Department of Financial Regulation to submit a state innovation waiver under section 1332 of the Affordable Care Act to establish a program for reinsurance and to seek federal pass-through funding of amounts attributable to premium tax credits under the federal premium tax, advanced premium tax credits.
So this was in one of the bills, it was in the budget, but since we're talking about trying to look at healthcare and reduce prices and all that, that just makes more sense to have it all be in here. This was something that came from the administration.
I have to present this.
You don't have, all you have to do is say there's no money.
Yeah, there's no fiscal, there's no
That's right.
fiscal impact. So
Right.
this we're taking out of the budget,
Right,
putting it into the bill.
right. That's all we're doing. Short report. Wayne.
Give us an example. Can you give us an example of something that would merit a waiver?
The reinsurance?
Yeah, no, yeah, right. So, get an event or something that would be done that would,
We have, for the record, with this, but we have not done a 1332 ever. The several states have for different reasons. It was added in the Affordable Care Act as a way to help states come up with ideas. Reinsurance is one of the places that some states have looked at using it. It's an idea around allowing states to, if they can achieve savings, to use the money in other ways. We have to look to get federal approval from the federal government.
so use flexibility to use if some under a certain.
We have a plan, saying we want to do this waiver to do this thing. And one of the big examples that when it was initially passed in the Affordable Care Act was to be able to do these like state-based reinsurance programs. There's one example.
So this just gives us the flexibility.
Right, this authorizes the administration to submit a waiver.
For potential
Request for-
future savings. And it was in our budget as it passed out, but it makes more sense to just put it in here. So we're gonna take it out of the budget and put it in this bill.
Assuming this passes.
Okay. Assuming, yeah, okay. So any other questions? Well, Jen won't go away too far, but why don't we get Chair Black up here to talk about a little bit more about things? We've heard some questions from committee members. We have some hospital trustees here on the committee, so.
For the record, Representative Alyssa Black, said you don't know much about healthcare, don't sell yourself short. You know what a Medicare EOB is, so that's then. And MEOB. So I think I'm more than happy to answer any questions around the underlying bill. But I wanted to I wanted to talk about the amendment, and I wanted to talk about the process mainly. Personally, transparency is very important to me. And I will just this bill, S-190, this has been a bill that has been being worked on since the beginning of this session with multiple stakeholders, administration, hospitals, the insurance companies, the Green Mountain Care Board, the Senate, House. This is, the ideas contained in here came out of a lot of working group of a lot of people. There were different things on the table. They morphed over time. The Senate would put something in, and then people would be running numbers in the background and then say, oh, we need to tweak this and we need to change that. Hospital budget guidance came out in the middle of this from the Green Mountain Care Board. So that had an effect on things in here. But at its core, this bill started as one purpose and one purpose only. Act 68 from 2025, we tasked the Green Mountain Care Board with implementing and starting reference-based pricing in fiscal year 27. That's October of this year. That is 5 months away. We knew it was a tight timeline last year, and they were not able to complete the rulemaking process. But that was the intent of the General Assembly. That was the intent when the governor signed that bill. We wanted this to start in 2027 fiscal year because it is really, really important. So the bill began as, what do we need to give the Green Mountain Care Board the authority to be able to move forward, notwithstanding the rulemaking process, which they will be complete with in maybe early 27, but not in time for this. So what can we do for them that the legislature can say, you can move forward? And then there were lots of ideas and lots of ways that we could target things. I want to make really clear, every single person in every single stakeholder group, we all had one thing in mind, and that was affordability for Vermonters. Everybody agrees on that. And the hospitals have, dedicated themselves with finding savings and, helping remove, I say remove money from the system, but decreasing the cost of care. And we wanted to target these savings to the markets that are most vulnerable. The QHP market. So it's made up of, I call it the QHP market, but it's really two markets. And Representative Dickinson, you were sort of getting to this. It is people who purchase on the individual exchange, normally self-employed people who do not have access to employer-based health insurance. You have to actually not be eligible for anything else to be able to purchase on the exchange. The other group, and they're about equal size, or they were about equal size until the subsidies, is a small group. Small group, these are small employers, or in Vermont, Like, you have to be under 100. But there are also employers that don't have the option of sort of going with any other possible mechanism to insure their employees. They're usually priced out of the self-insured market. They're too small. Maybe their employees are at a higher risk, so they're not able to get, they're not able to self-insure. So this is a market it's kind of the market of last resort for any small employer. These are our small businesses, and they have been bearing the brunt of these increasing premiums more than any other group because they've never gotten subsidies. The individual market subsidies, they haven't. And then the other group, obviously the VHI. We have heard over and over, and I know you have heard just as much as I have heard, education, property taxes. This is one thing that we can do right now to help taxpayers by decreasing the cost of school-based employees' health insurance. We can do that right now. And if we're gonna have these savings, let's target them somewhere.
So we have a question.
Yes, oh, I'm sorry.
So my question is, in the rulemaking process right now,
Mhm.
are you aware of whether the process is proceeding? I don't know if it's proceeding slowly or not, if it's on track or proceeding slowly. Is there any substantive reason for it to go slowly? Is there anything that you're aware of that might be problematic? Or is it simply procedural?
I think it is simply procedural. I do not think that it is dragging on. I will say that I am well aware of the people who are going through this process at the Green Mountain Care Board are trying to go as quickly as possible. You might want to ask them because honestly, I'm not an expert on
The
the
reason why I ask is
rulemaking process.
we have an amendment that simply is going to sidestep that, put it into effect before the rules are in.
For the first year.
For the first year.
We are making the rule for the first year.
The first year, we're doing something, so if there's something substantive that's being discussed, rulemaking process. So that's why I asked before, is there any way we can run off the rails by passing it now?
No, because we're only targeting it for this 1 year. So
It's a one-year
this
thing.
is a 1 year session law. It will go away. And the Green Mountain Care Board, who is working on reference-based pricing, have completed their rule. And then they will start implementing reference-based pricing for the entire commercial insurance market. So it is just allowing them for this first year to begin, because there will be savings coming out of the hospitals. The hospitals themselves have already committed.
Okay, so Tom has a question.
Yeah, I think it's a question. First of all, I just want to, after listening to Budget Council and to you and to your attempts, the healthcare committee's attempts over the years to wrangle this, and it seems from a distance, I'm not in your silo, so it seems from a distance that it's impossible. And I appreciate the efforts. I mean, every silo in this building, including ours here, can say the same thing, that it's impossible to do that which we are trying to do, which is make it cost less and be more affordable. And yet here we are putting our noses into the engine and trying to get it to fix. Using a simpler analogy, because this breaks my brain, and I'm not used to this vocabulary. I'm eating less food than I used to, but I pay more at the grocery store than I did. And that's what this sounds like to me, is that we're trying to reduce costs at some level, or usage or something, and yet it still costs more. So how is that? Am I off base in thinking that way in terms of what is it you're trying to manipulate here? That's going to be systematic and at least permanent for a little while.
I think, to use that analogy, we have been eating the same and prices just keep going up and up. And now we know we have to eat the exact same, And the only way, but we can't afford it because the prices have gone up so high and we're trying to reduce the price of groceries.
And and the effect of that though, and this goes to the education question, this goes to this question. So when I see that we want to lower this number to get back underneath what we think we can afford without necessarily increasing our income or increasing our ability to pay, is who's getting the short end of the stick? Is it in healthcare, it could be the manufacturers of Q-tips or medications or sheets or whatever. But when you say that the hospitals have reduced or have an idea of where costs can be reduced, I get worried that someone's going to get the short end of the stick, whether it's starting with the patient, which is the first thing I think of, or the client, or is it the amount of staffing? Is it the quality of machinery? Is it where is the fat in this system? And I don't know that there is fat. I can just, we all have very one-dimensional ideas of where there's too much expense. But what are you identifying in this to be able to, because I'm hearing a lot of, this is what we want to do, but I'm trying to get a concrete hold on what it is you're trying to do here.
Why is it every time I come to appropriations, I end up crying?
There's a box of tissues, somebody handed it.
We know that the monumental growth in our healthcare spending has been concentrated in two areas. Hospitals, specifically actually outpatient hospital, and prescription drugs. That is where we are seeing these two types of services are consuming more and more and more. And we can't afford it anymore. We cannot afford it anymore. And so what are we trying to do? Am I trying to hurt some hospital? No. But at some level, whose pocket are you going to reach into to pay for it? I'm not willing to reach into Vermonters' pockets anymore. They're the ones who have been paying for it. We have to bring costs down. We have to. We can't afford it anymore.
Well, we're the most expensive.
We are the most
Expensive
expensive
nation.
state in the entire nation.
Right.
And the US is the most expensive in the world. That makes Vermont number one in the world.
Don't want to be number one. This is a case.
This is
of
an
being
occasion we
number
don't
one.
want to be number one.
Right. I see hands raised. I've got Lynn and
And
Jane.
I just, again, I want to emphasize my appreciation for you carrying this and your committee carrying this and having that on your shoulders as you're trying to find a solution for all of us. I don't mean to be antagonistic. I just want to
Yeah,
make sure that we
no,
understand that the work that you're doing here is, while the details are important, I think we don't appreciate our own work, and in this case, your work enough. So
We all care. We all care about our local hospitals. Frankly, UVM is my community hospital. And UVM is probably targeted most in this. No one wants to hurt their community's hospital. But I don't want to hurt Vermonters anymore. And I know another thing. The Green Mountain Care Board, they don't want to hurt hospitals. They have been doing everything they can to sustain hospitals. Hospitals are closing all across this country. We haven't lost one. We're lucky. And I credit the Green Mountain Care Board with ensuring that. Everybody cares, but we can't afford it anymore. I wanted to make one last point about the amendment.
Then I've got questions.
Okay, so, there was this whole process, and the process was all these runnings of numbers and everything. And then it got to the very end, and we passed it out of House Healthcare. And then there was a concern that was raised that we weren't prescriptive enough, that we weren't constraining the Green Mountain Care Board it became about regulating the Green Mountain Care Board's hospital budget authority. That is what it morphed into. It stopped being about reference-based pricing and it inserted the legislature into a process of saying, Green Mountain Care Board for 2027, here's what your budget orders are going to be. We don't do that. That is long established. It is a process that happens every year. It is a very well thought out process. I encourage anyone to watch it it starts in March when they send out their guidance and they go through the whole process. There are dozens and dozens of people who work at every individual hospital, who work at the board, whose expertise in this area. And it is not the legislature's role to constrain the Green Mountain Care Board and tell them exactly what they must do and do a one size fits all. That's the amendment. The amendment is saying, here, Green Mountain Care Board, hospitals, go through your regularly scheduled process. And Green Mountain Care Board, if you're able to find savings at some hospitals, which hospitals have already committed to, then please go forth for this first year with reference-based pricing, which is what we intended and we wrote into law, and concentrate on these two markets that are going to help Vermonters the most. That's what the amendment is. So, thank you.
Thank you, Chair Black. Lynn and then Dave.
Yeah, I said this to you yesterday when we presented it. I said I directed it because you were sitting there on the side. But the conundrum that you have, the issue that we all have to face, is that you're relying upon human behavior to remain healthy. Because the cheapest healthcare is the healthcare you don't need. And I served on a school board, and we actually had, with our unions, agreed to go, our teachers agreed to go into what we call VISBIT, which was the Vermont Insurance School Trust, whatever. Apparently it still exists. At the time, it was created, and this is something that the associations that also were in the state also used as a model. If you had a healthy cohort of insured people, you were rewarded with a rebate at the end of the year. It encouraged and supported wellness areas, healthy people doing logical, good things to remain healthy. Now, these were employees, of course, but associated. The chamber had it. All sorts of different professional organizations had it. In a conversation I had in the cafeteria, apparently that ended with a lawsuit that got rid of that. VHI is a self-insured group now that does the teachers. And when we went toward trying to get a statewide process, the people who were affected the most, I suppose, from my memory serves me correctly, were the paraeducators and people who were the less paid. Sometimes they get more in benefits than they got in pay with that healthcare plan.
Yeah.
What, if anything, does this? When we got the ACA, we got rid of associations. But what do you do, or what can you do, or what kind of testimony did you get about trying to do things that are more healthy, keeping people healthy? How do you expect the hospitals, and any perspective on this, to try to reach out to reduce the number of people who get no care, show up at the hospital emergency room on Saturday night, or have every kind of chronic disease you can think of, and really just, where do we put that in here?
So you started with, that we know that if we can deal with prevention, actually, I frankly don't like to use the word prevention. I like to use more manage.
Yeah.
That if people are healthier, they will cost less.
Yeah.
I would also say that and you said that's the best,
Yeah.
most affordable care. I would say that the lowest quality of care is the care that's never received because people can't afford it. We are watching right now. We have seen almost a 20% loss in the individual market, the individual QHP market. We've lost close to 20% of people that were in there. It's something like 5,000 people. That happened on January 1 with the loss of the enhanced premium tax credits. Those are people who were in that market because they didn't have other options for employer-based insurance. We don't know where they went, but I am deeply concerned that they have no insurance. We had Dr. Stephen Loeffler, who's the CEO of UVM Health. I'm still trying to not say network. They dropped the network. UVM Health. And he testified in our committee, and he was talking about how they are taking in close to $500,000 more per day than what they had budgeted. And that has nothing to do with the rates that are being set. It has nothing to do with the any action the legislature has taken or that the Green Mountain Care Board took. That is being driven strictly by utilization. We watched the QHP market go from people, like the majority of the market were in gold plans with very low out-of-pocket costs or lower out-of-pockets. And it has almost completely flipped over where all those people are now in these high deductible. If you are a family on a bronze plan, your max out-of-pocket is, I think, $40,000. And you're paying close to $35,000 a year just for a plan you cannot afford to use. That is what I am concerned about. I'm concerned about people not receiving care. That is what is going to hurt our hospitals the most. If people cannot afford to use the care, they are not going to receive services at their hospitals. And that is what is going to have the most profound effect on the financial stability of our hospitals. That's where the danger is. It's not in a 0.5% reduction fight between Green Mountain Care Board and a hospital. That's not what's going to do it.
Okay, I'm going to move on to Dave. I think healthcare is like education. We can all talk about it all day, but we're going to move on and
Thank you.
reschedule the agenda. I'll tell you later.
I'll try to be,
Go ahead, Dave.
my concern is whether the Green Mountain Care Board has the tools, the statutory authority, whatever they may need to assure the public is safe. It's one thing to say you have the authority group to set what people can charge, tied to some reference, et cetera. It's entirely another to say you shall be able to intervene with surgical precision and say, you should do this or you should do that. People may argue, good Lord, don't give the authority to do that kind of micromanagement to government. Yet without it, what if a hospital said, we're so excited, not excited, but we're meeting our obligations, we're reducing costs by closing a birthing center. And 200 women are now forced in the dead of winter or anywhere to travel sometimes up to an hour to deliver their babies at a cost significantly higher than at the birthing center that closed. No money was saved. But it looks like on my balance sheet, I'm able to say to the regulators, look at this. And are the regulators helpless? Maybe the wrong word. But are they unable to say, wait, there's consequences to that. You shouldn't do that.
Mm-hmm.
Maybe you should look at the fact that your CEO at your critical access hospital is the highest paid in the state. I say these things not to be uncomfortable or unkind, but to make my point. There is a whole array of expenses in hospitals, and are we who are we giving the authority to make these kinds of community decisions to? Not criticizing the healthcare committee, they've been working hard.
I'm gonna ask Chair Blatt to answer that,
Yeah.
and I look.
My question is simply, does the Green Mountain Care Board have the authority to protect people?
This is the beauty of reference-based pricing. Because I listened to what happened this past summer in your community. And this is why we designed, and this is why we have given the Green Mountain Care Board authority to be able to design discrete reference-based pricing. Other states have just said, okay, public employees won't pay over 250%. That's what other states have done with reference-based pricing. We wanted the Green Mountain Care Board, and I know that there are a lot of really smart people who are working on this right now. We want them to develop reference-based pricing so they can do because they know the challenges of, say, Copley. If Copley is recommending that they have to close their birthing center because they're losing money on the birthing center, the Green Mountain Care Board can say, hey, Copley, we're going to set your reference-based price higher than other facilities because we want to ensure that you are providing the services that your community needs, and your community needs this. As opposed to, and they can do that for Copley, and then they can set somebody else's prices lower. You know, perhaps instead of paying $12,000 at Copley and $30,000 at UVM, they will say, UVM, you're going to get 18, and Copley, you're going to get 18. They can level the playing field, and that is why, and reference-based pricing, it'll probably never be over. It's an iterative thing. And that is why we're doing the statewide strategic plan in collaboration with the Agency of Human Services to come up with a plan of, okay, what does Morrisville need for services at their hospital? What are the essential services that hospital service area needs? And the board will be able to then say, what are we doing to ensure that they have the resources to encourage the services your community needs, instead of what happens now with our RVU and RVRVS system and DRG system and PPS this and critical access that. We have these payment models that have been developed over dozens and dozens of years that incentivize providers, hospitals to provide the services that they get the highest reimbursements for in order to subsidize the services that are essential to communities. And that's the beauty of reference-based pricing, is we can disrupt this system to ensure that we're paying for the services that Vermonters need, and not just let's buy a fourth MRI machine, because if you buy it, you will fill it.
Thank you. Understood.
John.
Yeah, I don't have a question,
Oh, okay.
All right.
but I have a couple of things I
You
want to.
are welcome to make a statement. Go ahead.
Talking about.
I don't, we never want to pick you Friday.
I know.
Very weepy lately anyway, so anything.
I think-
We're gonna wrap up, folks, because we've been here for a while.
So I'll be as brief as I can. I think one of the things that kind of adds to the whole mix of everything here is a lot of the stuff we've been talking about here. Demographics are changing here. You know, hospitals, their payer mix is way different than it was when I first got on their board 6.5 years ago. And so I'm very familiar with the process of how we try to determine our budget based on the budget guidelines that Green Mountain Care Board provides. And sometimes it's really challenging because the cost of some things are just simply not under our control in terms of, you know, contracts we have and our nurses and our doctors and other staff that, you know, provide the services here. But I think one of the things we've been seeing here in a significant way are two things. we have patients that have come to us and have gone to other hospitals as well, that if they don't receive some medication that will keep them functioning, to keep them alive, the cost of a lot of those things is significant. And I will say the Green Mountain Care Board has been very good in working with us to not count that against our larger expensive things, because we have medications that cost like $1 million for the year.
Yeah.
I think we've all talked about that last year here. So we've had some relief there, and we're very appreciative of that here. I think, and then with some of the change in demographics, some of the services being offered across 2 or 3 hospitals, it's changed here for sure. And each hospital, especially in the rural areas, they only have so much capacity. And sometimes the capacity is not great, and they may make decisions that we have read about here recently here. And those are not good things. And perhaps that was not the best decision to make. I don't think it was, quite frankly, here. Because some of those services, we may not have large volume to like pay for that area, the hospital. We understand that, but we have other areas that do pay. And there's some shifting going on. I know with the 2 regional hospitals in my area here in St. Johnsbury, up in Newport, we're starting to try and share a few things to kind of save on cost. And that's been a very positive thing here. But we're also seeing more patients coming from one hospital to the next here because there's only so much capacity for actual care and service. And that does drive up 2 things. Revenue here, obviously here, no one complains about that, but there's also expense tied to that too. And I think our hospital is just looking for better predictability so we can be more assured of our sustainability with the services we're currently offering here, because our communities need those types of things. And I guess one of the concerns I had was about a question I asked about rulemaking.
You said you had no question.
Well, repeat what I asked, not ask you to respond to it. So, but I think, there's been some time for that rulemaking to take place here. And it concerns me that we're not quite there yet. We're going to move into like a next year. And I understand that takes time. We'll be careful about that because words matter, just like words matter and all the things that we review every day here. So it's a big conundrum here. And I'm a little unsure. I don't disagree with moving things forward here. I think Green Mountain Care Board probably already has the capacity to start doing that. They started doing that last year. As soon as we moved out of this to start talking to hospitals about this. And I just want to kind of make sure that the hospitals are able to respond in the most timely way to provide what they need to here and vice versa as well. And that's my big concern.
Yeah, and I will say regarding the reference-based pricing and the ability for the Green Mountain Care Board to do just this discrete part of it, the reason the numbers were changing so quickly in this bill, and they were changing like almost daily, it felt like.
Ability thing that was just.
Well, no. They were changing because like a new number and the calculation to get to those things like the 250, the 300, the 350, those calculations were made via an email sometimes. Hey, how much would this be? So, this is just, I'm considering this a reinforcing our intention of Act 68. And you talked about predictability. I did want to mention reference-based pricing is established in Act 68, but ultimately by, and I don't know the date, it's 29 or 30, global hospital budgets. There's your predictability. Once hospitals have been right-sized and they are able to provide the services that their communities need, then we are moving to global hospital budgets. But we just want to, I do not think this is a difficult task for them to do in this year. And this year we have the opportunity to really help Vermonters. We have the opportunity to ensure that people are able to receive the services that they need so they're not getting sicker, so that they're able to go to their hospital and not fear a $30,000 bill. That's what this is doing for 1 year.
And we have a larger issue, which is that we're a small state and we have these big problems and we can only nibble around the edges of a lot of this. And some of this ought to be national, not statewide, but here we are. So I think everybody, hospitals, Green Mountain Care Board, healthcare committees, or everybody's trying to do the best they can to ensure people get what they need and hospitals survive and patients can afford to pay for their care.
And I know that this committee is very familiar with what is happening on the federal level to
Yes.
many multiple different systems, including and especially the QHP market. I won't even get into what happened this week
Yes,
on
some
the federal
other
level. That's
federal stuff. We'll hear about that at some point. So thank you very much.
Thank you.
So we still here. I think the order is we should pass our amendment. And then we vote on the bill as amended, and then we take a straw poll on the other. I'm looking at Jen. That sound all right to you? Okay, so we're gonna do 3 votes. 2 are they're all real, but the third one is a straw poll. Okay, so back to our amendment, which is just transferring something that was in the budget to this bill. Is there a motion to support?
So moved.
Thank you, Dave. Is there a second? And thank you. This is the easy one. Okay, if there aren't any further questions on this, so we're just voting on the appropriations amendment to the bill 190. Let's call the roll, please. Thank you.
Representative Lindley,
Yes.
Representative Dickinson,
Yes.
Representative Feltus,
Yes.
Representative Kaczynski,
Yes.
Representative Roche,
Yes.
Representative Wiki,
Yes.
Representative Nigro,
Yes.
Representative Squirrel, yes, Representative Stevens.
Yes.
Representative Yakavoni,
Yes.
Representative Shaw,
Yes.
11-0-0.
That's 1100. So now we're going to take up the bill as amended by us, but it's probably amended a few times.
Yeah, it's as passed Senate and amended by House Health Care and further amended by Health Care and further amended by Appropriations.
I don't know if we have 2, we don't have 2 healthcare amendments because we're not doing the second.
Right, so 3.
I'm sorry?
Bill as amended by the Committee on Healthcare.
As amended by appropriation.
That's fine.
Committee, not
Okay, right. That's right, not Black's amendment. Yes, Dave, is there a second?
Are we voting on the amendment from the healthcare committee?
The bill, no.
Yes.
Well, no, we are voting on draft 3.3 of S 190. That's the full bill. That's 16 pages long that we just amended. So it's that bill as amended by this.
This,
We haven't gotten to that's the straw poll.
So the second, the amendment that we heard from the representative
Will be a straw poll. And this is our vote of our committee on S 190 as amended by us. Tom? Do we already have Dave? Do we have Dave and Tom? Dave and Tom, okay. I may be making that up, but I think I saw you raise your hand.
I did it.
Okay.
It's okay.
So are we clear? So this is the original bill that we got
Yes, a little bit.
as amended, so it's not the Black amendment. Everybody good on that? John, are you clear?
I just need to think for a minute. I'll see you.
Okay, so this came out of House Healthcare
We reviewed
1010.
this, when a lot of this was what had already been passed. But then came out of the Senate, some of the language.
Are you looking at the 16-page bill?
The 16
Okay, good.
page bill.
All right.
Yeah, no, yeah.
Okay, all right. So just as a reminder, the bill itself came out of healthcare on a 10-1 vote. Not the amendment.
This came out of 9-2 vote.
10-1.
10-1, sorry.
I wrote it down, 10-1-0. Everybody good?
What if you're undecided?
We have a responsibility to vote.
I think some of our concern is, what about the Black amendment?
Okay.
Yeah, it goes together as a package.
I want
We-
to, depending on,
Oh. So if we voted on this,
okay.
I think we can
Let
segment
me
this.
just say that I think that I was not inclined to want to vote on the Black amendment until the representative explained
okay,
why she's doing the way she's
Okay.
changed the way it
Okay.
is. I understand other people voted against it, but I'm not gonna,
don't worry about it. I think it was,
what I think is that it almost was like a pilot of the larger amendment
Mhm.
Just do 1 year. Got that?
Yeah, well, the Black Amendment is directing activities for just 1 year.
Yes.
And then the rest of the bill says, here's what we think is going to happen in 28 and 29.
So package wise, it's really kind of ends up going.
It is together,
So.
but I think we have an order. I mean, do you want to do the straw poll on the amendment before you do the bill? I'm not sure that works. No, sorry, Jen, can you help us out here? We have to vote on all three, I guess, and if you know where you want to end up, if you voted no on the full bill, straw poll becomes moot. Right, but if
So, Jen Carvey, Legislative Council, if there is, if people's support for the bill is contingent on the Black Amendment language, then one possibility would be for this committee to propose the Black Amendment language as part of your committee amendment. And then people could support.
then we can support the whole thing.
It's the point of this, which is.
Right.
Yes.
Right.
So one could vote no on this.
Yeah, okay.
You see what I'm saying?
Yeah, so Jen's just said, if that's really important, if the Black Amendment's really important, do we want to adopt the Black Amendment as our own? And then we can amend S 190. And we would do the bill as amended.
That sounds cleaner.
Yeah.
It does sound cleaner. Are people okay with that?
I mean, the purpose.
Enough people okay with it?
Yeah, I think I like that better.
I have a discomfort. I'm not exactly knowing exactly why.
Okay,
So can I restate this?
yes,
So putting aside what we just voted on for our own.
yeah,
right?
that's still
All right,
fine.
that's just there, that's just the
Yeah,
technical change. Essentially. So what I'm hearing is that if we amend the bill as whatever the version is, but if we amend the bill with this Black Amendment and call it ours,
yeah,
then it will gain more support, at least within this committee, because there will be an understanding that we just improved the bill as opposed to here's the bill and, oh, we're going to improve it over here.
right,
And so rather than having a messy vote of 7-4 on the bill
Right.
as we amended it versus whatever we would get, however many votes it would, I'm just saying it.
it sort of
From a
guarantees
floor-
it gets into the bill.
Right.
Right.
From a floor perspective, though, it just seems easier and cleaner for us to amend the bill so that when it's on the floor,
Yes,
it's just when you vote for this amendment, here's
Right.
this bill, explain, and then here's this amendment that fixes that,
right,
which overrides.
yeah,
Okay,
that's,
if I heard that correctly, that's what
Right.
that's what I'm envisioning.
right,
Okay, as I look at the bill, the 16-page bill.
yeah,
The amendment that I think is the pilot,
yeah,
section 2.
right,
Takes out those other years.
Right.
It's only 27.
Yes.
Now, I do have a question that I didn't really get a chance to ask the member from the committee. And that was the question on the external entities.
Oh, which section was that?
That's in section 4 that we have to go. I mean, there are lots of things that hospitals have contracted out for.
Oh,
Emergency room is one of them. I
I'm
think radiology is one of them.
glad you would ask that question.
I'm just gonna keep us going.
Okay.
I'm sorry, I missed it.
So,
Explain to me where that comes from and what difference.
So
should it make?
honestly, where it came from was, in the hospital budget process this year. Several hospitals were coming in and, they were contracting out their services. Like there was one hospital who was contracting out their hospitalists. Those are basically the
Yeah,
attending
yeah.
physicians.
Yeah.
One was actually moving, I think, the emergency department back in-house, but it had been separate. There's instances which we've sort of known about a long time, radiology, pathology, things like that. But it kind of became a little jarring in this year's hospital of, wait a minute, the Green Mountain Care Board actually has, I mean, I'm sure they have in some regard, but have they been adjusting the budgets for hospitals when hospitals actually remove the service and the billing from the hospital. So if you're building a budget based on last year's budget and your order is you can increase 3%, you're increasing 3% on a budget that was approved last year when those services were in-house and now they're out of house, which is driving up the cost of care. This part of the bill is really, and the thing is, remember, hospitals pay a provider tax. So when you remove services and you're billing them separately, the state is not receiving that provider tax. And this is really, hey, let's look and see how this is actually affecting, because it has not been, and yes, there have been there are some emergency departments. It's not all of them, but there have been at times. And they also do a lot of locum tenens, but that's still in-house. Yeah.
Yeah, I'm just concerned because one of the things that my experience or my understanding is that a lot of times they did this because they saved money.
Yes. But if they're saving money, is that being reflected in their budget orders?
So the budget doesn't take out what they have to only budget for their own
However, it still has
services.
to budget. I have to pay this contractor $1 million for.
Yeah.
I mean, it's still there as part of their
But
budget.
some of
In a
them are,
different way than they would be budgeting.
but some of them are not working like that. What they are is they're contracted providers who actually, they are the ones doing the billing. So it's not being billed by the hospital, which means the provider tax is not being
But the
collected on
expense is
that.
still included in their budget.
Not if they're, well, it could be, could not be. That's why that's what this section is like, we should probably look at it.
Clarity to it.
It's a report.
It's a report.
Okay, so Jen is drafting the Black amendment to be the House Appropriations Amendment.
You just sent it.
You sent it to me. So we know what it is. It's now going to be changed to say House Appropriations.
And I will say that I thoroughly appreciate that because now I'll be able to do the appropriations amendment to my committee. And I think my committee has had some additional time. But as I said, it happened really quickly. So
You posted Autumn?
Yeah.
I'm just going to assume it's right because it's Jen.
that's usually my assumption also.
The only thing I changed in it is in walking you through it, we started by saying just the board, because I pulled it in from statute, and so I made it say the Green Mountain Care Board, yes, Care Board.
That sounds good.
Otherwise, it is Black amendment with the House Appropriations Amendment. House Appropriations Amendment is the third instance and the effective date begins the fourth instance.
Okay. All right, is it posted on? Okay. So we can withdraw our other amendment that we just did because you added the reinsurance amendment to this. So we don't have two different pieces of paper floating around. This would be the one that we would give to the clerk's office. You want me to just send it via email to the committee?
Put it up on the screen if you want.
Why don't you do that?
Posted it.
All right. But yes, Jen, if you want to just throw it on the screen quickly. So I don't know how we do this, Trevor. We kind of cross off that other one. And we're gonna have a new amendment.
Yeah, but it's fine.
Just tear up that piece of paper.
Yeah, whatever.
I'll use this for right.
Oh, yeah.
Change the version.
Can you let me back in?
Official office that folks have.
Great. All right, I'll just show you the Word version. Let's.
Does this show up on our website as the same one? Did you delete the other one? To the new one?
No, I
Get a 2.1 or something.
All right, I will forward this to the committee. I'm going to forward it to House Appropriations, so you'll have it in an.
Thank you.
That may be the fastest way to get it.
All right.
I just emailed it. And I just got it, so you should have it. And Jen has it on the screen.
Yes, and it's on the screen.
Okay,
We have on the screen striking out section 2, putting in the new section 2. That's just the one hospital fiscal year. The one change that I made was it had said in subsection B, it had just said the board. I added in the Green Mountain Care Board.
Okay,
And that was the only change there. Otherwise, it's the same language that you had looked at. So just, it doesn't specify the percentage, just
Right.
order
okay.
hospitals to reduce their.
And then, go
And
ahead.
then we have the second instance of amendment is striking section 3 and deleting it. Third is your new reader assistance heading and section 4A on reinsurance. And then the fourth instance of amendment is striking out the effective dates and putting it back in as just
Right.
message.
Okay, all right. Well, everybody has it. Okay. Thank you for doing that so quickly, Jen. This is why we have to take the room. Is everybody clear on what we've just done? Okay,
We turned it into universal health care.
that's right. That's next page.
We could have saved us 2 hours.
I know. Okay,
Preparing to leave the state.
all right. So now, is there a motion to approve the new House Appropriations amendment that we just saw? Tiff, Dave, any other questions on this? You okay, Wayne?
Not really, but I'd just like to know if anybody in the room, is there any reason for us to be nervous about this?
Go ahead,
I'll
John.
jump in real quick. I just want to be reassured this rulemaking is going to happen.
We have the Executive Director of the Green Mountain Care Board here. If you'd introduce yourself, Emily.
Go through and then take it. So it's going to happen. It's going to happen. Before.
Emily Brown. So I just want to add a little bit more context to what Chair Black testified to. So part of the reason why it's also taking longer is because this is a brand new program, we had to get a contractor. And that, as you all know, takes time, that process. But we now have one on board, and so now we are able to officially start drafting our rules. So it's just, we had like a 2-step process that we had to do to get the rulemaking, and we have a timeline. It's going to be hopefully finalized by early. So we are working on it and we can help build it.
So that will be ready by 28.
Correct.
Okay, great. All right, okay. Are we ready to vote? We already have a motion and a second. I've kind of lost track of where. Okay, so clerk, everybody call the roll, please.
Representative Bloomley,
Yes.
Representative Dickinson.
Yes.
Representative Feltes,
Yes.
Representative Kaczynski,
Yes.
Representative Roche.
Yes.
Representative Wiki.
Yeah.
Representative Nigro.
Yes.
Representative Squirrel, yes. Representative Stevens.
Yeah.
Representative Yakavoni.
Yes.
Shaw.
Yes.
Somebody-
So now we are going to do the bill as amended with our amendment in there, right, as
Amended by healthcare, amended by.
and amended by appropriations. So now that our amendment is in that bill. Okay, is there a motion to approve that bill? Dave, God. Sorry. Did somebody second?
Which day?
Go ahead, Tom.
It's the ties.
Yeah, it is the ties. Is there a second? Yes, Dave. Okay, great. Any other questions or comments on the bill? If not, let's call the roll.
Representative Bloomley,
Yes.
Representative Dickinson,
Yes.
Representative Feltes,
Yes.
Representative Kaczynski,
Yes.
Representative Roche.
Yes.
LaRoche. Representative Wiki.
Yes.
Get out of order here. Representative Nigro.
Yes.
Representative Squirrel, yes. Representative Stevens.
Yes.
Representative Yakavoni.
Yes.
Representative Shaw.
Yes.
7-0-0.
All right. Great job, everybody. I so appreciate everybody who's been in the room and hanging in there with us as we got through this. I think we're in a better place than we were before. And Lynn, is this yours to report?
I reported, yeah.
That's got more complicated.
That's okay.
It won't be today. All right, committee, before everybody runs off, which I know you want to, we're gonna hear the cannabis bill this afternoon at 1:45 and the Miss Ag bill at 2:30, and those were our last two bills. They should be a lot faster than this bill, but we didn't